I think ranitidine is discontinued, right?
Mhm.
And then proton pump inhibitors really are the ones that work the best. These are approved after age 1. So between 0 and 1, you're going to be a little bit limited there for at least safe treatments.
What's your opinion on activated charcoal?
For GERD,
Yeah.
I've never used it.
Okay.
So I don't know. It might work in the short term, like if they show up at the emergency department with it.
So what is the, I mean, has there been any studies to compare like barium to activated charcoal, like how the efficacy is?
Not that I know of.
Okay.
I don't know.
Curious.
Yeah, that's an interesting question. I just don't know the answer. I could pretend like I knew, but I don't, which I do a lot too. All right. So, how do we treat it? Well, so if there's just esophagitis, right, it could take 4 to 5 months to heal. So, you want to talk to them like, say that you broke your leg or you have this huge cut, right? Well, now you have cuts in your body, in the esophagus. So, even when we start lowering the pH, it can take a really long time to heal. If it's refractory, then and it's caused by like an anatomic abnormality, and we do all the testing to confirm, then they can do this procedure, the Nissen fundoplication. Wow, that's really cool. But anyway, they just basically wrap the stomach around there to create a false sphincter. But we don't really want to have to do that if we don't have to, right? That looks crazy. All right. So other etiologies. So eosinophilic esophagitis. This is obviously an immune mediated. There is an allergic component because those eosinophils are associated with allergic reactions. And there's some trigger that's triggering the release of the eosinophils, and then they're dumping all their granules and causing chronic inflammation, which causes this scarring. Okay, so you just have this really scarred esophagus. Normal esophagus should be nice and pink, and these esophaguses are just so scarred up that they've got layer on layer on layer of dead skin cells, and so they look kind of dark and definitely more disturbing than a normal esophagus. So this can be diagnosed on endoscopy and after a PPI trial. It's treated with topical steroids, so they actually swallow this liquid that you make for them. And then we want to try to see which type of foods might be triggering this, or if there is a trigger, we want to try to find that. So here's some other etiologies. So there could be erosions of the esophageal tissue. There could be a foreign body. So sharp objects, magnets, we're going to have to go down there with an endoscope and grab those and pull them out. There's your coin. Okay, there's a coin down in that bowel. The ones that are really emergent are when people swallow batteries, like these kids swallow a battery or something like that. We've got to go down there and get it because it can basically ruin that esophagus, and then it'll eat right through the esophagus. So that's not good. If it's lower and they're asymptomatic, we might be able to just follow it through. So if it's already got into the stomach. So I had an interesting case. I had a little girl come in who had eaten 3 magnets, but she had eaten them in a group. So they're like those little magnetic balls. If you eat one and then it starts to digest and then eat another, then they can stick together in the bowel and necrose the bowel and you can die. But she had eaten them all in one clump. Like she was playing with them in her mouth. She was like 12. And then she like, oh crap. And so we took a picture and there was 3 little magnets and they were all stuck together in the stomach. And, did all the proper phone calls, and the GI, he was this old salty GI doc from down south. And he's like, oh, she'll be fine. You know, just if she gets worse, have her come back. If not, don't. And I was there for the next like 4 days and she never came back. So she either went to a different hospital or never had a problem. All right. So burns, right? Burns are a big deal for upper GI stuff. Kids will ingest caustic liquids, which will cause them to burn. The problem is not the initial burn, it's the necrosis after, and it's the swelling of the tissue. And so that's what we really worry about. We want to definitely refer these children. We're going to call the tox center. There's a toxicology number, and you can always talk to a toxicologist. Yeah, poison control. And you can talk to them, and they're, yeah, but I never call, only for work. I'm like, get me that number for stuff that people drink that they shouldn't. And they're like, okay. They speak to him, so they know. All right. So non-ulcer dyspepsia, acid that's irritating the stomach. It's causing discomfort, bloating, and maybe some nausea, but no vomiting. It's the same treatment as GERD. If it's unresponsive, then they may need to do an endoscopy or an upper GI. Basically, it's the same thing. There's just no ulcers. So that you could call that a gastritis if the stomach's inflamed. Nausea and epigastric pain. This is kind of the presentation of peptic ulcer disease. So you've got these ulcerations, and then the pain is going to increase with eating, okay? So when you eat, you produce more acid. That acid irritates the ulcers. That is synonymous with a gastritis or a gastric ulcer. Sometimes too, in the proximal duodenum, you'll get that same presentation. It's usually younger children, and they might have this poorly localized kind of peri-abdominal, usually epigastric discomfort. Associated symptoms, if they're really concerning because they have weight loss, bleeding, or a perforation, then we really want to jump on these and do something more. So peptic ulcer disease, it's an imbalance in the acid secretion of the mucosal defense, stomach or duodenal mucosa breakdown, and then that causes an ulcer. Causes include NSAIDs, H. pylori infection, stress, and Crohn's disease. So we definitely want to do H. pylori testing. You can also do let's see. You can also do an endoscopy. The stool antigen test. What are the two ways we test for H. pylori? And what's the difference?
Well, breath urea, they have to discontinue PPIs for 2 weeks prior to testing. I don't know shit about stool testing.
Right. So that's the money shot right there, Cody. The money shot is that if you do breath testing, the patient has to stop their PPI for 2 weeks. So like somebody with really bad GERD, it's really tough to make them stop their PPI for 2 weeks. So if they're miserable with their GERD, then you just do the stool test. Now you need to explain that to them because they're not going to really want to do the stool test. Most people don't want to do the stool test if they don't have to. And so you're going to explain why they really have to do the stool test instead of the breath test. Because I've had patients say, well, can't I just do the breath test? Because, you know, everybody's got somebody that talks to them and tells them, well, I just breathed in this bag. It was so easy. Why can't you do that? Well, because you can't. Because if I take you off your PPI, you're going to get really bad. Okay. So how do we treat this? Well, we want to suppress the acid. So we do PPIs, which are the most effective. They're more effective than the H2 blockers. This is once we know that it's actually an ulcer. Okay. If we're just suspecting GERD, then the standard of care is to start with an H2 and then move to a PPI. The antacids may help with immediate discomfort. If they do have H. pylori, then it is triple therapy for 7 to 10 days, which is your omeprazole, amoxicillin, and clarithromycin. So basically 2 antibiotics and an acid suppressor. There's a whole bunch of different regimens here, but this is pretty much an easier one to memorize. But yeah, so we want to make sure that H. pylori is not overlooked. So there's going to be a lot of overlap with these gastroesophageal disorders. There's going to be differences in clinical presentation. There's no real take home for each of them. It's basically, you want to make sure that you're able to differentiate certain tests and certain buzzwords that might suggest that it's something else other than something else. In the real world, what we do is we usually throw some spaghetti at the wall and we see what sticks, okay? And that's just the bottom line. You usually try something because it's going to give you some good information, and then you move on from there. If they're refractory, then they're going to go to GI. All right, constipation. Want to take a break? Let's take a 5-minute break.
The tink, tink, tink.
The timpani?
Yeah, for like the constipation, and like I think proximal to it is like the gas. So those two, you'll have the obstruction, which will cause the tink, tink, tink on all sensation, and then you'll see the gas and imagery after that.
Sometimes. Are you talking about with a bowel obstruction?
Yeah.
Yeah. So with
That could be malignant or fecal, right?
bowel obstruction,
Yeah.
usually the bowel obstruction is caused by like a surgical abdomen, some scar tissue. And then it's kind of, you can almost kind of think about it like an intussusception. But basically something causes the bowel to get stuck. And when you're listening for like physical exam wise, sometimes you'll hear like hyperactive bowel up into the obstruction. So it's like.
So like obstruction, anus, like stomach. So which like beyond the obstruction?
Yeah, so before the obstruction. So think about this. You've got this obstruction in the bowel somewhere. And the obstruction, so say it's constipation or a lith or something like that. So you've got this bowel, and then you've got something obstructing the bowel.
When those muscles are an actual thing.
Right. And so this is, what happens is the bowel continues to peristalsis. Okay. So then this kind of gets widened because you get gas and fluid building up. And what you'll hear is this is still trying to push. So it's like.
So you'll be hearing all that traffic jam shit.
Yeah, so this would be hyperactive bowel sounds. And then this is usually hypo.
Oh, okay.
So it's hyperactive before the obstruction.
So this is like poor man's imagery, so you're
Yeah, I mean, I should be able to
the mass
do
just
right
based
after.
off of sounds.
What's happening is they're vomiting.
Okay.
That's a bowel obstruction. They're vomiting and they're not farting.
But it's small or just either.
Oh, okay.
That's those are the two key pieces. It's this is cool to know, but they're vomiting and they're not making gas. They don't fart. Now, ask them, when's the last time you farted? Shit, I don't know. And they're vomiting.
We should ask
Me too. Okay, so constipation. All right, we've all been constipated, right? We know what that means, but we need to have a definite criteria for this. So usually it's like 5 days of not having a stool. So that's usually what I tell parents, because they'll come in after like 24 hours and be like, my kid's constipated. Like, yeah, I'm sure they probably do have a little bit of upset stomach and they probably haven't gone to the bathroom, but that does not mean that they're like clinically constipated. So Typical stooling pattern for an infant is going to be greater. So it's about 4 stools per day. School age children, it's about 1 stool per day. But constipation or the prolonged constipation is actually called obstipation. And that's usually about 4 or 5 days. That's when we actually want to get a little bit concerned. So we might ask about some of the consistency, frequency. Are they working hard to go poop? What's the poop look like? So medically, we can define constipation if there's less than 2 stools per week, or if it's this hard pellet type stool for greater than 2 weeks. Most common cause is functional. Okay, so we just don't know, but basically, we see that they're constipated and we never figure it out. And then we give them something to make them not constipated and it works, right? So that'd be functional or idiopathic constipation, right? The bottom line is kids don't drink enough water, and that's the problem. The distal bowel is where we dump water back into the stool. And so if there's not enough water, this is when you want to look at their lips. And if their lips are dry and cracked, then they're not drinking enough water, and that's the problem. There can be some uncommon organic causes. So if you want to go zebra hunting, you might think about Hirschsprung disease, a neurologic abnormality, or hypothyroidism. All right, so here we're going to belabor what functional constipation is. Basically, it is just that they are intermittently constipation. They have intermittent constipation. The pattern may be these hard, infrequent bowel movements or small stools that are not very robust or allowing them to fully void their bowel. There can be some pain. They might be trying to hold their stool. Like some kids don't like to go to the bathroom at school, which I can't hardly blame them. But that can cause constipation. If there's bleeding or leakage, that is definitely a sign of a big constipated something there that that you're leaking stool around it, and that's definitely a problem. We've got to get that out of there. We want to review their past medical history, and then we also want to review their childhood history. Functional constipation. So we're going to do a good physical exam. This is consistent with a neuro exam too, to make sure that their nerves are functioning correctly. We might palpate something in the abdomen, right, in the left lower quadrant. There may be some, if there's undergarment soiling or something like that, we may do just a kind of visual rectal exam. Definitely want to have a chaperone in the room. Even if you've got a parent, you still want to have like an MA or something there. You put their name on the chart. Just because the world that we live in, we need to just make sure that we're protecting ourselves and our patients. You don't do an actual rectal exam. So you're not going to insert your finger. You're just going to observe the rectal tissue, right? So they can take a diary, you know, how much water are they getting? What type of juices are they using? What type of fiber are they intaking? Sometimes just adding like a Metamucil or something like that will be effective for these children, and might help them to add some fiber to their diet. Usually the diet's just really poor and they're not getting enough water. That's usually the biggest cause. Echoparesis, so this is involuntary stool leakage around a fecal impaction. So you get this impacted fecal matter and then they leak stool around it. That's caused by chronic constipation. That's obviously a problem. We need to either refer to GI or disimpact this patient. So management of echoparesis is basically, it can be a psychological basis. We don't want to give them any blame or make them feel like it's their fault, because that obviously is going to cause, I mean, if you're leaking stool, you're not going to feel really great about yourself, right? So we want to make sure that these kids get some positive reinforcement and that the parents aren't being extra hard on them, because there's probably some obstruction. It's not their fault. We've got to help them get through that. Bowel training is good. So just having the children sit on the toilet for an extended amount of time, like, once daily after school, they just sit on the toilet, read a book or whatever, so that they get in the habit of using the toilet and kind of training their mind and body to work together. You can do like a clean out regimen, like magnesium citrate or something like that, but just know it's gonna really clean them out. And then we definitely need to work on diet. Okay, so 5 fruits and vegetables. I don't think most of us ever get that. So I'm a big fan of smoothies. So I usually educate my parents on giving the children smoothies and making them taste good, because that's a good way for them to get a bunch of fruits and vegetables in at one sitting and then kind of move their bowels that way. So some more, this is that postprandial bathroom time. So after they eat, they can read their baby newspaper and sit there for 5 or 10 minutes. This foot support, the squatty potty. Have you guys seen that infomercial? Yes. So that might be helpful to kind of put them at a different, at a different angle, which seems to help them eliminate their bowels a little bit better. If you do have to give a child an enema, there's some kind of positioning technique. It's not very cool, but at any rate, it is good to know, because if you ever have to do that, you kind of want to position them safely and comfortably. The disimpaction regimen is usually to use a glycerin suppository or a Fleet's enema. So it's not like old people where we go in there and dislodge the stool with a digital extraction. It's usually done with the Fleet's enema. For maintenance, they can use stool softeners such as lactulose or PEG. There's also lubricants that can be used, like mineral oil, so they can actually ingest mineral oil. And then stimulant laxatives, which we want to use sparingly, or like Senna and Doculase. Positive reinforcement. So here's Johnny's voiding chart. Okay, when he goes poop on the potty, he gets a star, and then maybe at the end of the month, he gets some big reward. That's always a good thing. Positive reinforcement works a lot better than negative reinforcement. So that's something, I mean, it sounds goofy, right? But you're going to actually be telling this to people. This is the profession you have chose, okay? So you will do this. So it is good to have these skills. These are life skills that you're trying to give to parents. So basically make sure that you have that kind of normal maintenance so that these kids can get on some sort of a schedule. We want to define if there's an impaction or not, and if we need to repeat the enema. We can do that with an x-ray of the bowel, okay, like a KUB or something like that. We want frequent follow-up until we've got this problem kind of fixed. I like to keep my patients kind of do this frequent follow-up until we get the problem taken care of, and then that seems to make a big difference. Oops. All right, so what's Hirschsprung's disease? So Hirschsprung's disease is a neurologic condition where the ganglionic cells do not migrate to where they need to be. And so the colon doesn't basically work the same. So you have this spasm and narrowing of the affected section of the colon. So it's basically a ganglionic issue in the colon, and that's called Hirschsprung's disease. So if you hear that in a history of a patient, you want to kind of, oh, these are the things that you like tuck away. And then 6 years later, you find some kid with Hirschsprung's and you're like, oh, yeah, I remember something. I'm going to look that up, right? But it just tells you to look it up, and that then you can say why this is a problem. So clinically, they may have, we're probably going to catch this in the newborn. They may have delayed stooling or recurrent constipation as a newborn. 75% are going to involve the rectum and distal sigmoid. So Hirschsprung disease, here's that Hirschsprung's. So you've got this big inflated colon. So this colon kind of follows this, like, it looks like a box. And so you go up the colon here for the ascending colon, and then the transverse colon, and then down. And here's that most persistent site of this Hirschsprung's disease. And here it is in that sigmoid colon, right? And then sometimes you can also call this the splenic flexure. So it's where this bowel comes around the spleen and then down to the bottom. The transition zone is where it goes from normal to abnormal. All right. So how do we diagnose this? Well, what they do is they do a biopsy, and the treatment is to do this pull through procedure. So what they're basically doing is pulling the healthy part of the colon over and then eliminating the part that has the diverticula, or the ganglion that do not work correctly. So you won't be doing any of this, but it's just good to know that that's how they do it. And the prognosis is actually usually very good if we identify this early and treat. Adverse food reactions. So adverse food reactions can be caused by like food poisoning. There can also be non-toxic forms of this, like non-immune, which would be like a lactose intolerant, or immune mediated, which is a food allergy or food sensitivity. So some of these are driven by IgE, mediated by IgE. So the body's producing IgE in response to certain foods that it sees as an allergen. This can be as a rapid onset in the GI, skin, and respiratory. This can be caused by peanuts, eggs, and shellfish. Non-IgA mediated are gradual onset, like they can have proctocolitis, so inflammation of the rectal portion of the bowel, the sigmoid colon, and the colon due to breast milk, and then they may also have celiac disease. So an interesting little pearl here is if somebody comes in with an allergic reaction, so they've got swelling of their lips and tongue, shortness of breath, wheezing, and they're complaining of abdominal pain, that is actually more consistent with anaphylaxis. So those people get the EpiPen. Sometimes the only symptom of anaphylaxis is abdominal pain. So don't blow off somebody who thinks that they're having an allergic reaction and they're complaining of abdominal pain. A lot of times I've seen providers do that because we just don't know what we don't know. So always be humble, because there's so much stuff that you don't know. Even this program is not going to teach you 25% of what's really out there. You're going to learn the big stuff, but there's always going to be stuff that you don't know. So never blow off people, and always be humble and try to work through things together, because sometimes you'll find things that are really weird. Okay, so food allergies. The most common food allergies are milk, soy, egg, peanut, tree nuts, seeds, shellfish. Clinical symptoms include basically everything from mild itching and hives to anaphylaxis. More concerning if they have abdominal pain or vomiting. Okay. How do we diagnose this? Well, allergies are really tough to diagnose. There's definitely a lot of difficulty in diagnosing allergens, either oral antigens, allergens, or skin allergies. IgE assays can be okay. However, there's a lot of limitations to these assays. In order for your IgE levels to be triggered by these foods, you have to have eaten that food. So you could have a peanut allergy, but you haven't had peanuts for 2 years, and then you go get your workup and it's like, oh, you're not allergic to peanuts, because your IgE levels have titrated down so far. So just keep that into the back of your mind. I used to think, oh, I'm a lab guy. I'll just do all these allergy things on people because I'm so smart. I'm not smart. I figured out that that's not the way to do it because you get really inconclusive results. And then you're stuck trying to tell the patient, well, but we don't really know, blah, 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 blah. So don't oversell these tests. If they want to do them, meet them in the middle and you can do them, but preface that with, sometimes these come back and they're kind of confusing and they're kind of expensive and blah, blah, blah. At least so that they have, an idea of what to expect. You want to make sure that their expectations are in line with reality. Immediate treatment, you're basically talking about antihistamines and steroids, epinephrine injection if that's not initially working. One rule of thumb and thing to know is that IV steroids, PO steroids are just as effective. So if you can't get an IV in a patient right away, just throw 50 milligrams of prednisone in their throat and call it a day, okay? And then if you're really worried there's any swelling or airway involvement, then get the epi on board as fast as possible. So here's kind of how you inject that epi pin, right? Shove it right into your leg. Awesome. Okay, allergic proctocolitis. So this is a non-IgE mediated allergic process to milk or soy protein. It's a hypersensitivity reaction in infants, and they're often infants that are breastfed, okay? So they may have blood streaking in stools in an otherwise healthy infant. So they're growing normally, they're behaving normally, they're eating well, but there's some blood streaking, which is different than bloody diarrhea, okay? I had this history from some child and I was a little bit suspicious just because, and I did do an ultrasound and it turned out to be an intussusception. So don't be fooled. You still have to rule out the bad and the uglies. Here's the thing. Don't ever hang your hat on something simple, right? Hang your hat on that later after you've ruled out the scary stuff. Like the 20-year-old female that comes to you with palpitations and is super anxious, it's really easy to be like, that's anxiety. Well, that's your license, okay? So take your time, always be in the patient's best interest. If you were that patient, would you want somebody to blow you off and say it's just anxiety? Or would you want them to say, look, personally, you seem pretty anxious. I think this might just be anxiety, but in the fact, in the chance that I'm wrong, which I've been wrong before, let's make sure that there's no problems with your heart first, okay? And here's what we're gonna do. And then come up with a plan that both of you agree with, because then they'll feel like they were heard, like they might actually buy your diagnosis, but if you just blow them off, then they're gonna, like every other doctor blew them off before they got to you. So at least work them up properly, and then they might buy into your diagnosis, okay? So put your biases aside, always. You can have biases in the back of your mind, but don't let that play into the way that you treat your patients. Okay, so this usually resolves at about 12 months. We may have to transition these kids to a different form of intake. The protein in the breast milk is what induces this proctocolitis. Celiac disease. So celiac disease is this autoimmune disease that is not really greatly understood until recently. We're doing a lot more diagnosing here. Unfortunately, patients do a lot of self-diagnosing too, which is okay. However, you don't always get true data to support it. But I mean, the treatment's not really aggressive or harmful for the patient. So, whatever. But basically it's an autoimmune small intestinal pathology. This is kind of the mechanism here. So you've got this antigen presenting cell that gets triggered by intake of basically antibodies that are made to wheat in certain products like wheat, rye, and barley, and the protein that they contain. And then these cytokines trigger this cascade. What happens is the cascade disrupts the cilia here. And so they're not absorbing very well at the bowel, and it can cause really bad problems. Back in the day when we didn't really know much about celiac, some of these people would get really, really sick. Now I think it's usually something that people will try, you know, like you have some problem and then you decide to take wheat, rye, and barley out of your diet, and then you improve. So it's difficult to diagnose because some of the things like I was talking about with the IgE testing is that if they're not intaking wheat and barley, then they'll titer off. So what lots of times the clinician will have them intake those, which make them feel terrible, and then check their levels. And a lot of people don't want to do that. And that's okay, right? You know, they can manipulate their diet. It's a little bit more expensive for them, but if it makes them feel better, it's usually in their best interest. So, so what's the presentation? So it's estimated that 1 in 100, and it can present at any age. Classically, it's from 6 months to about 2 years. They're going to have some bloating, diarrhea, and they may have failure to thrive in like the real true celiac disease. Older children may have this chronic abdominal pain. They might be short in stature and may have some delayed puberty. So in that case, I mean, that's a real disease, right? So we want to keep that in the back of our mind. We don't want to assume that, oh, you know, because I think right now it's difficult because so many people are like gluten-free that you think like, oh, it's not like really that bad. But it really can be a bad disease. So kind of keep it in the back of your mind if you've got this undifferentiated abdominal pathology, that sometimes this can present, you know, there's a spectrum of presentation, and sometimes they may present like really, really sick. And we want to make sure that we at least consider that and think that that could be part of their problem. So classically, they're going to have GI symptoms. They may have some non-GI symptoms. There's an increased risk if they have diabetes or first degree relative with celiac disease. So actually my sister-in-law has like true celiac disease. And then they had one of the kids, the first boy was tested and he tested positive. And then the second boy never got tested because they were just like, well, there's like a 50% chance. So let's just treat him with the food and call it a day. The only definitive test is a biopsy of the small bowel. And so it really is pretty aggressive to like definitively diagnose celiac disease. So here's the tests, super kind of confusing tests. I wouldn't get too wrapped up in this. If it's really super high yield, then we'll review it again because it is kind of difficult and it's not really super, it's not really easy to grasp these tests. But basically, you've got serology testing. So you're looking for elevations in IgA, 2 different types of IgA, and then this TTG, which is tissue glutaminase. Wow, that's a big one. But anyway, see how the sensitivity is pretty definitely ranges. That TTG is by far the most sensitive and specific test. So that's probably the biggest take home from that whole slide, is that the TTG is the most sensitive and specific. So if somebody hasn't had TTG testing, then you basically want to make them do that. And the EMA, which is your anti-endomycin antibody, is fairly specific and sensitive as well. So I guess you can't really tease out which one of those is the best, but I think that the TTG testing is more commonly performed in the real world. But if there's serology that looks abnormal, paired with the clinical suspicion, then you can refer to GI for a biopsy. And here it says before treating. I don't know, treating's pretty simple. It's just manipulating the diet. So a lot of people are going to elect to not have a GI biopsy, which I think I probably would too. So I can totally understand that. But that's a conversation to have with your patient. And that way you're honest with them and explain to them, like, we can assume this is celiac, or we can confirm it with a small bowel biopsy. And that's what we do. And then anyway, so lifelong gluten-free diet, it's going to increase the cost. So it's about 30% more. But, really, this probably not as expensive anymore because there's more gluten-free stuff on the market. So as competition increases, so does the price goes down. A nutritional consult might be a good thing, especially if a patient doesn't really know a lot about this. There's a lot of information out there, but some of your patients that maybe don't read at a really high level, or are not the patients that are like going to go sleuth the internet, you might want to get a nutritional consult on board. Plus, if you do go sleuthing the internet, it could be really super confusing and not very helpful. You want to monitor for signs of anemia. So they may have difficulty absorbing iron. So they're going to have what type of cells? Microcytic hypochromic cells, because they're small cells with not a lot of iron in them. Okay. Yeah, everybody knows that. So iron deficiency anemia is going to be microcytic hypochromic cells. So basically it sounds fancy, but all it means is small cells that don't have a lot of hemoglobin in them. So when you say hypochromic, it means not a lot of hemoglobin. And when you say microcytic, it means small. So they're going to have a small MCV, which is going to be microcytic. And they're going to have a small MCH, which means hypochromic, which you guys get into next. So I'll be quizzing you on that stuff. Okay, so bone metabolism might be affected again because it's lack of absorption. They're not able to absorb calcium, phosphorus, and vitamin D as well. And then total protein and albumin and maybe even liver function could be definitely monitored in these patients. So we want them to adhere to a strict gluten-free diet. If they do that, then they'll most likely remain asymptomatic. Within a year, we'll do the serology to see how they're doing. And if the villi, right? So it's the microvilli in the gastrointestinal tract, if they've normalized. So what you would have to do then is do another biopsy. So in reality, this doesn't get done very often. Future treatment is looking at some enzymes that can digest gluten so that they can still eat gluten, but the enzymes will break it apart for them because that's what they're lacking, is the ability to break it down the way that we need to so that the body can absorb it. And then the polymers that can bind gluten peptides so that they don't trigger the immune response. All right, inflammatory bowel disease. You guys see how much like overlap there is with this ped section? That's why there's not objectives, because why do the same objectives twice? Unless you guys want special objectives, I could hook you up. We can. Anyway, inflammatory bowel disease. All right. So inflammatory bowel disease is an encompassing term. It's going to encompass ulcerative colitis, which is in the colon exclusively, and Crohn's disease. Okay. UC and Crohn's are completely misunderstood a lot of the times, but they're really not that complicated. Crohn's is from mouth to anus. Okay. UC is strictly in the colon. Okay. So the etiology is likely genetic, but we cannot exclude environmental. So that the real take home is that basically it's idiopathic. The peak onset is from 10 to 20 years of age, but as early as the first year of life, we might see this. So here's the pathology. Basically, you have this chronic inflammation that leads to this thickened wall of the colon, and then you start to lose these cells as they slough off. Okay, chronic inflammation is a bad problem. And then you get these pseudo polyps, which are basically outpouching of abnormal tissue. This is just scar tissue in the bowel. Okay, it all sounds really complicated, but it's really not. It's scar tissue of the bowel. Okay, so you get this scar tissue in the bowel. That's not good, right? And it doesn't look good either. So you can put all these fancy terms with it like pseudopolyps and cobblestoning. They're probably good to know. That is not going to differentiate between ulcerative colitis and Crohn's. The only difference between the two is one is in the colon and the other one goes from the mouth to the anus. Okay, so any question that you're going to get on a test is going to have to define that for you. So don't spend your time trying to get into the little nuances. You'll know if it's exclusively in the colon, ding, ding, ding. They can put 17 different sentences in there to throw you off. But if it's exclusively in the colon, it's ulcerative colitis.
They also did talk about if the question is clearly going towards inflammatory bowel disease, if it mentions anything about the anus in the question, the answer is Crohn's. I remember reading that too.
Yeah, because it's if the anus is involved, right? The anus is not involved in ulcerative colitis. It's just the colon.
But the skip lesions is signature to Crohn's. I mean, it's cobblestoning, but you are going to have the skip
lesions. Yep. And so some of those they will talk about, right? And I think we even get into those too. So ulcerative colitis, difficult part is that ulcerative colitis is in the colon, but there can be some manifestations outside of the colon. Now that's not talking about the mouth and the anus, right? So it's manifestations in the eyes and in the biliary tree. These are called extraintestinal manifestations. So you can have sclerosing of the ducts that go into the gallbladder. You can also have some skin lesions, and you can have uveitis.
They talk a lot about for like colonoscopies. You know, I had polyps removed the last time, so I had to have my colonoscopy more frequently and yada yada yada. Are those polyps, are they capable of becoming malignant, or what is the purpose of removing them?
Yeah, so polyps traditionally are like an adenocarcinoma. There's a whole bunch of different kinds. That's why they actually do pathology on them to see. And what they find in that polyp itself will guide when they have to have a colonoscopy, or if they're going to go in there and remove that portion of colon. So they take the polyp out because they don't know. It could just be like a skin tag type morphology. And then when they do the frozen sections and they look at it, they're like, oh, it's just like no big deal, right? It's just like a skin tag, but it's still epithelium basically. And then they can also see pre-cancer, and then they can see active cancer. So they don't really know until they clip it and then they test it. So those, they don't just cut them off and throw them in the garbage. They cut them off and send them to the pathologist, that weird guy that sits in the dark and makes frozen sections. And he looks at them and then he says, suspicious for blah, 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 right? So that's what guides the follow-up.
What's that eye condition called?
Uveitis.
Oh, okay. Just in the bottom.
Yep. So inflammation of this conjunctiva. Okay, clinical manifestations of Crohn's disease. Okay, so you can have systemic, and they may predate the GI symptoms, and are more common than in ulcerative colitis. So poor appetite, growth failure, delayed skeletal maturation, delayed puberty. This depends on the areas that are involved with the gastrointestinal symptoms. You can have postprandial abdominal cramping. You may result in small bowel obstruction. That's probably the same thing that we talked about with those Peyer's patches. Basically, you've got inflammation in the bowel. The bowel's contracting. It's going to fold in on itself, and that can cause a site of obstruction. That's not necessarily an intussusception, but you can think of those kind of interchangeably to a point, but basically you get where the bowel is stuck and the stool's not moving, and then you get backup, and that's a bowel obstruction. What are the physical exam manifestations? How do you know it's a bowel obstruction without doing anything? Cody can't answer because he already knows the answer because I talked to him on a side note. How do you know it's a bowel obstruction without doing any tests? They're vomiting. They're vomiting and they're not passing gas. So I'll actually ask the patient, did you fart today? And they'll be like, actually, no, I didn't. Or they'll be like, no, I just did. Can't you smell it? Right? So that's going to differentiate if it's a bowel obstruction or not. They don't pass gas because there's no movement distal to the site of obstruction and they're vomiting. Okay. That's a bowel obstruction just clinically before you do any imaging. All right, so what are the manifestations of Crohn's disease? Well, they can have, here we go, mouth to anus, right? Aphthous ulcers, arthritis, erythema nodosum, clubbing, erythroschleritis. So that's kind of an evil one, right? Because that's inflammation of the eye too. But basically, don't get tied up in that. Just remember that eye inflammation is not going to be a distinguishing feature. Sorry. All right. They can have gallstones and they might have renal stones. Those things are not going to be distinguishing features either. So irritable bowel disease, symptoms can overlap, especially with Crohn's, right? So they're going to have chronic abdominal pain. They might have some weight loss. They might intermittently have fevers. They can intermittently get colitis. They can have some diarrhea with blood, mucus. They can have cramping. It's just kind of this disorder that masquerades as everything else. So the thing that you need to remember about irritable bowel disease is kind of what I talked about with other things. Irritable bowel disease is a diagnosis of exclusion. Do not diagnose somebody at the start with irritable bowel disease. Thanks, have a good day, bye. Right? Because there's all this other nasty stuff it could be. IBS is really, or irritable bowel disease is really not as bad. Irritable bowel syndrome and irritable bowel disease are not exactly the same. It is the disease state when you have, it's kind of like azothemia and uremia. They like to use the terms interchangeably, but they're really not. So irritable bowel disease is when you've got chronic abdominal pain, weight loss, and fever. So you have some sort of infectious process on top of the fact that you probably have irritable bowel syndrome as well, okay? Right. So toxic megacolon can cause systemic toxicity. The colon gets super inflated. It is greater than 6 centimeters. When you're looking at the x-ray, that is indicative of toxic megacolon. It's this big, huge colon, okay, on x-ray. They're going to be sick as stink, okay? If they have a toxic colon, then they have a bad infection. They're going to have a high increase in white blood cells with maybe a left shift, and they can have some fecal protein loss. And this is a life-threatening condition that we immediately need to treat. So inflammatory bowel disease, what are some of the non-specific symptoms or signs? Would be a CBC with maybe anemia and some elevated platelet count. Remember, platelets are an acute phase reactant. So when people are under stress or they're really sick, their platelets are going to go up, okay? They could have elevated SED rate and an elevated CRP. Don't hang your hat on those, but definitely I think the SED rate would be elevated. If they're really in a bad state, their CRP is going to be up as well. And they might have low serum albumin because the inflammation is not allowing them to absorb protein properly. There's some specific antibody tests that you can do. These anti-neutrophil cytoplasmic antibodies, that ANCA is the most common. It's going to be positive. It's basically going to tell you there's some anti-nuclear antibodies at work here causing this problem. And these anti-sarcomyces, whatever, ASCA, is more common in Crohn's disease. So ulcerative colitis is going to be here and Crohn's disease is going to be there. So inflammatory bowel disease can be used as this encompassing term, right? Because now you're throwing, this is where it gets confusing, right? Because I know this is irritating. I get it. It irritates me too. But you're saying loosely inflammatory bowel disease, right? Can inflammatory bowel syndrome cause inflammatory bowel disease? Yes. Can ulcerative colitis cause inflammatory bowel disease? Yes. Can Crohn's disease cause inflammatory bowel disease? Yes. Break it down to its definition. What is inflammatory bowel disease? It's an inflamed bowel, okay? Simple. Keep it simple. Use the KISS principle, guys. Don't get so wrapped around your own brain. All right. So we want to diagnose which inflammatory bowel disease it is, and the only way we can usually do that with a colonoscopy, a biopsy, or you can do this cool little video capsule pill that they can take and it can see all the way down, okay? Then you have to have, obviously, somebody smarter than us read that as they watch it go down their system. Now, remember how barium enema always seems to be like the fix for everything? Don't give somebody with a toxic megacolon a barium enema. You will kill them, okay? Not a good plan.
So is that the only hard contraindication for barium? is that?
I don't know for sure. I hate to say only, but I think that's the only one I've usually seen.
Why?
I think because you've already got this inflamed colon and now you're pushing more into it. And so you're pushing all this extra fluid and the colon's already at max capacity. Yeah, so it's going to increase your risk to perf. All right, management and prognosis with ulcerative colitis. So 20 to 30% of these patients may spontaneously improve. Amino salicylates, so basically aspirin that doesn't get absorbed systemically, but it stays in the bowel, is kind of the hallmark of treatment. And then steroids intermittently. So I had someone that had a history of IBS, but then she'd get flares where it'd kind of go into this disease state. And so what did I try to do first? I just put her on some steroids to see if it worked. And it didn't. And then she went to the ER, but I gave her good return precautions. And I said, look, if, and she texted me, I was like, go to the ER. Like, I can't really, if the steroids work, cool. If they don't work, well, you need a bigger workup because you're pooping blood and that's not good. Which really turned out to show nothing. I mean, they did a huge big workup on her and basically said, you need a colonoscopy. So it was the right choice to try. What I try to do is think about what is the ER going to do. So when you do your rotations and then you go back to primary care, think, what's the first thing they're going to do in the ER? Well, I can do that. And then I can also give them good precautions in my note. So if they do decompensate, then they go to the ER. If they're stable in your office, you can probably try the first few steps. You don't always have to freak out and send people to the ER. Just do the first few things that they're going to do, like tap the joint, right? All right. So here's the treatment for complete resolution. You just take out their colon, right? That's probably not the best idea. I don't remember the last time I took out a colon. But if you have to, that's what they do. Refer them to GI and they remove the colon. So the prognosis is basically they're going to have these intermittent exacerbations. and there's an increased risk of colon cancer from the chronic inflammation. All right, Crohn's disease. So how do we treat that? Well, basically the same way. Aminosalicylates and steroids, and then they can have surgery. What's the prognosis? Recurrent flare-ups, and there's a high morbidity due to extraintestinal symptoms, the inability to absorb things properly, and the chronic use of steroids. So those will be for all those. Cystic fibrosis, what's that caused by? Well, there's deficient chloride channels. It's going to be in the airways, the sweat glands, the pancreatic ducts, the biliary trees, the intestines, and the vas deferens. So what we need to know about cystic fibrosis is it's not just the lungs and the pancreas like we think. It's really a systemic problem. The chloride channels don't work anywhere, not just in the pancreas, not just in the lungs. They don't work anywhere. So this is really a multi system type disease. You might find pancreatic with CF with the GI manifestations of cystic fibrosis is the pancreatic exocrine insufficiency. So malabsorption of fat and failure to thrive. So what does that mean in real language? Tell me if I'm a patient what that means. You're going to go in and say, you have pancreatic exocrine insufficiency. Thank you. Right. So you're not able to absorb stuff very well. Okay. The exocrine insufficiency is basically saying that you're not secreting, your pancreas is not working very well to secrete insulin, right? And then also throughout the bowel, you're not absorbing things very well. So low protein, you're losing your proteins or you're not able to absorb protein. So you don't have that oncotic pressure. Oh my gosh, oncotic pressure. Oh, you have to remember renal and GI. That sucks. Right? Well, welcome to medicine. So if you don't have the oncotic pressure, then you're going to have peripheral edema because you're losing the fluid to the tissues. They can have this really foul smelling stool called steatorrhea, basically because they're not absorbing, they're not properly breaking down things, their flora is all screwed up, whole bunch of things. Your bacteria in your gut do such a good job of breaking things down and absorbing stuff that since they can't do that in these patients, then they have this stuff called steatorrhea. It's really greasy, gross stool. Okay. They're not absorbing their fat soluble vitamins, so they can have deficiency in A, D, E, and what is that? K. So what else are they going to do? They can't absorb vitamin K. They're going to bleed, right? Because what are your vitamin K dependent factors? 2, 7, 9, and 10, right? So, oh my gosh, and hematology. GI is so evil. That's why you do GI later, because you're supposed to know all this stuff, right? And well, you don't know hemoc yet, but you will. Okay, so you're going to have thickened intestinal mucous membranes. Newborns can have a meconium ileus. Yuck. All right. Older children can have an intestinal obstruction. They can have a whole bunch of different manifestations. It's just good to know that that's part of it. We can give them pancreatic enzyme replacements, so a lipoproteinase. We can give them vitamin supplementations. We want to make sure they're hydrated. And if they're obstructed, we can use PEG. Eventually, they might have biliary stasis because the gallbladder is not able to contract as well. They can end up with cholelithiasis for the same reason, and they can have complete loss of their pancreatic endocrine function. So it's really a sad disease. All right, infections. Yay. So loss of appetite, abdominal cramps, diarrhea, nausea, vomiting. We've all had it, right? It's no fun. So by far, your biggest infections are from 70 85 to 90% are your rotaviruses, your other enteric adenoviruses, norovirus, all those viruses are the key cause. There's also bacteria causing pathogens like Shigella, Salmonella, E. coli, Campylobacter, Yersinia pestis, and Clostridium. You can also get parasites such as Giardia, Entamoeba, Histolytica, and Cryptosporidium. Those can all cause GI manifestations. So acute gastroenteritis, AGE, is inflammation of the stomach, gastrointestinal tract, and intestines is the enteritis part. So inflammation of the gastro and inflammation of the intestine. This is always needs to be diarrhea and vomiting. Do not diagnose someone with gastroenteritis if they do not have both of these features. You will be a poor clinician, okay? If they're vomiting and they're nauseous and you think it's gastroenteritis, then talk about it in your MDM. But your diagnosis needs to be the symptoms. The diagnosis can be vomiting and nausea. That is a perfect diagnosis. That way, when they bounce back, you have not basically oriented everybody's brain to thinking that this child just has gastroenteritis. You're saying, no, they've got vomiting and they've got nausea. In my MDM, I'm going to say, I suspect that this is a gastroenteritis that will eventually progress to diarrhea. However, I have not ruled out. If they come back or they bounce back, then make sure we do a more formative workup to make sure that this is not the case. All right, so management of acute gastroenteritis is we basically got to get these kids hydrated. So if they're severely dehydrated, that's greater than 10% water loss, they're going to be lethargic, unable to drink, tachycardic, sunken eyes, cold, molted extremities, or they have poor turgor, then we better put an IV and start bolusing these kids. What's a pediatric bolus? 250 mils.
To what age?
When they're tiny. You know, after that, you can go up to 500. I don't know. There's probably some chart for it, but I usually start about 250 and then I get them on a drip, 125 per hour after that. But you can bolus them, bolus, wait, recheck vitals as you go. And then they usually turn around pretty quickly. So minimal to moderate dehydration, that's less than 10%. Their exam is going to be normal. They might be fussy, fatigue, maybe some dry mouth, maybe decreased urine input. They may have a slightly increased heart rate, but they're going to have good perfusion. These can usually be managed outpatient with oral rehydration. What's the key? What's the key between putting them in and putting them out? Can they tolerate POs? That's the key. Sometimes medicine is simple as just, you get all this extraneous stuff and it's like, if they're vomiting and Zofran's not working and they've got vital sign changes, they're coming in. Okay? Like my little girl, gave her Zofran. She vomited the first Zofran, gave her another Zofran under the tongue, petted her hand, right? She kept it down. She was tolerating POs. I document she's tolerating POs. If she gets worse, come back. If somebody's not tolerating POs and they're showing signs of dehydration, you cannot discharge them.
Is that just like, is that a distraction? What is that?
I don't know.
Petting her hand?
Whatever.
What are you doing?
It worked, dude.
Fair enough.
I actually did not pet her hand, but I mean, with my, personality, I just went in there and owned the room. No, she just chilled out. Like she was just worked up and it was like, oh, it's a cool girl. It's a cool lady. You'll be fine. And she was. Okay. So it was a metaphor. That's what it was.
I thought you were actually petting her hand.
No, that would be weird.
Why is that?
That would be weird. Thanks for clarifying that.
Yeah.
Appreciate it.
You are being recorded.
Yeah, exactly. Okay, so oral rehydration. If they can tolerate it, that's cool. They don't have to go in-house. They can go home. Antiemetic is great to use. Usually I'll have them break it in half because it's usually like a 5 milligram tab. They will get a bad headache if they take too much ondansetron. So if you give them like just a half a tablet and it works, and just keep giving them half a tablet about every 4 hours, and that would be cool. Rotavirus. So we do vaccinate for rotavirus, right? I think it's right,
Oral one, right?
right about a year. Yeah, it's the oral vaccine. I don't know, when do we do that? Does anybody know?
Yeah, so Rona, you start at 2 months, 4 months.
Oh, so it's a,
Damn, Corey.
I mean, I worked in peds for a year now.
okay, so it's the 3 series then. Okay, cool. So, and then more common in the winter months, symptoms include vomiting, watery diarrhea, dehydration. Most severe in infants. Usually, therefore, that's why we came up with this vaccine. There is a rapid antigen test, and the treatment is largely supportive. Bacterial infections, so Shigella, they're going to have a high fever. They could possibly have a seizure. This is called dysentery, when they have blood, mucus, and foul-smelling diarrhea. The strains are going to produce this Shiga toxin. So Shiga toxin is synonymous with Shigella. In the lab work, you're going to do fecal cells. So you're going to have them look at the stool. Like, remember that physician asked me to look at stool? If I would have looked at it and said there's a bunch of white blood cells in there, that's what he wanted me to look for, right? If he would have saw that, he would have said, well, I think this is Shigella. Maybe we should keep this kid, you know, and do some supportive stuff. Stool culture will also show you that. And then the treatment is usually actually to treat the infection. Some of these bacterial infections, though, we don't want to treat. So that's where we need to identify the pathogens, because like E. coli 0157, we don't always treat with antibiotics because it will release its endotoxin and it will make you even more sick. So oral azithromycin and cefoxamine, which is a, what is that, a 3rd generation cephalosporin. IV ceftriaxone, so that is, yeah, probably 3rd.
You've got some chats.
Okay.
Erica wasn't saying that. I'm over it.
Let's see what they got.
They might be-
Cool, that makes sense. Oh, they got it. Can you hook me up with those cheat sheets? No passing gas. Okay, cool. All right. We'll touch base too, guys, at the end. If you any questions you have, we'll answer them. Okay, so salmonella, right? Consistent with typhoid fever. There's also non-typhoid salmonella. So comes from animals, mostly dairy. So your eggs and poultry, reptiles, turtles. So that's a good thing to ask people. Like, do you have a turtle at home? You know, so that's something you would never think about, but it's something that you need to know. They can't have fever, and they're going to have this bloody diarrhea. They possibly could have bacteremia. So this is a sick patient, right? If this patient's septic, we're going to really jump on them and make sure that we treat. We're not going to physically jump on them. We're going to metaphorically jump on them, and we're going to treat them quickly and make sure that they are treated appropriately. If they're less than 3 months old or with sepsis, we really want to treat this super aggressively. All right, E. coli. So there's a whole bunch of different E. colis. There's enterotoxogenic E. coli, which is this ETEC. There's enterohemorrhagic E. coli, which is EHEC. I don't think you guys need to get too wrapped up in that. Just know that there's different types. That's pretty much the take home there. And then there's the enterotoxin, which causes this secretory diarrhea, which is a really watery diarrhea. And that's the cause of what they call traveler's diarrhea. So basically, they present really all the same. You can try some Imodium in these guys and see if it slows them down, as long as they don't have a fever, okay? So if you've got a really high fever, you don't want to slow down the diarrhea. You actually want to let it just keep happening so that they're getting rid of the pathogen, and then you're just going to keep them hydrated, okay? Okay, so E. coli continued. So there's this E. coli O157H7, which produces a Shiga-like toxin that causes bloody diarrhea but is self-limited. So in these people, we just do intensive supportive care. We don't want to treat with antibiotics because if we treat them, they'll release their exotoxin and they cause a lot more trouble and people decompensate very quickly. However, the toxin, if absorbed, can cause glomerular damage in the form of an acute kidney injury and also can cause hemolytic anemia. So what kind of bilirubin is going to be elevated in this patient, direct or indirect? Sounds like you're guessing. So, yes, what does the liver do? Conjugates bilirubin. If a blood cell is hemolyzed before it gets to the liver, what kind of hemoglobin, what kind of bilirubin is going to be in there? Unconjugated, okay? Unconjugated is synonymous with what? Indirect. Remember this, directly from the liver. Directly from the liver. All right, so hemolytic uremic syndrome can be caused by this bacterium.
I got me and my fat ass over
So hemolytic uremic syndrome, basically what is that, right? So you get glomerular damage, you're gonna build up nitrogen waste products, which would be called what? Azothemia. And when you start to have secondary cause from that, like bleeding or some other confusion, pericarditis, uremic encephalopathy, it's called uremia. So I had a patient, I always have a patient that has Saturday at Trios. This was the worst nosebleed ever, okay? It was the weakest nosebleed ever. So she comes in and she's like dabbing at this nosebleed and it's just barely on the paper. And I'm like, hey, how about you quit dabbing your nose? And she's like, okay. And she keeps dabbing her nose. And I'm like, there's something wrong with this lady. Like they're just, my gestalt is like, do labs, Tim. And I'm like, okay, fine. So, you know, we do the Afrin and we pack it and then pretty soon she pulls it out and dabs it and it's bleeding. And the nurse is like super pissed. She's like, by the way, she's bleeding because she keeps dabbing her nose. And I'm like, I know, but there's something like, she's not all there. Like there's something wrong with this lady.
An older lady?
No, she's like 50.
Okay.
But she just kind of had that like little yellowy look to her and she just looked sick. And I'm like, not like really yellow, but just a little tinge. And I'm like, something wrong with this lady. So I'm like, do you have problems with your kidneys? And she's like, yeah, I do. And I'm like, do you dialyze? And she's like, yeah, I do. I'm like, when's the last time you dialyzed? Yesterday. And I'm like, okay. So I do some labs on her. Her labs come back with a creatinine of 16.4 and a BUN of like so high that they can't even like beyond reportable, and a potassium of 6.8. So then what do I do next? An EKG, right? So then I do an INR and an EKG and all this other stuff, and I scan her brain. So she's got end-stage renal disease. She said she dialyzed Friday. It's now Saturday. And I'm like, I'm telling her like, you didn't dialyze yesterday. And she's like, yes, I did. And I'm like, no, you didn't. And she's like, yes, I did. And I'm like, no, you're lying to me. And she's like, she's so confused that it's like not worth it. So then her husband calls and he's like, don't let her fool you. She didn't dialyze since the 1st of October. So she had no EKG changes. And the hospitalist was busting me. And she's like, well, why are we admitting this patient? And I'm like, because she has a potassium of 6.8. She needs emergent dialysis and she has uremic encephalopathy. And so the uremic encephalopathy was the reason to admit. So when you speak in their terms, they back down. she was like, oh, okay, this guy knows what he's talking about. So I will shut up and I will just take the patient. And everybody was like, have you talked to this hospice yet? She's really mean. She always bucks the PAs and da da da. And I was like, bring it. And so once I used that term, she was like, I'm like, she's encephalopathic. She has uremic encephalopathy. We need to bring her in and fix her. And I was like, when it's azothemia, it's my problem. When it's uremia, it's your problem.
You actually said that to her?
Mm-hmm. And she was like,
Damn straight.
Oh, snap.
she was like,
You right.
okay, what's the medical record number? I'm like, yeah.
Give me my face.
Okay, so moving on. So yes, this can cause hemolytic uremic syndrome, which is bad. All right, so parasites, we always want to keep those in the back of our mind, right? Giardia, caused from drinking water. So a lot of times I'll ask people, did you go camping? You know, did you play in the water? Sometimes you just don't find out, but you just have this good suspicion. So you can do stool studies for Giardia antigen. You can do an ova and parasite analysis where you'll see the cyst from the parasite itself. The treatment is metronidazole or albendazole. Here's another parasite, Endomoeba histolytica, which is just the amoeba. It's going to cause dysentery. The treatment is metronidazole and this other quinolone. Most pathogens are from contaminated food and water sources, so just make sure that people are washing their hands properly. So even if you didn't drink the water, you may have played in the water and then ate food, and that's how you could end up with Giardia or something like that. So that's why it's important just to ask if they have that history of camping or something, because that makes you more suspicious. Or they play in the ditch, you know, the kids go and play like in the ditch water and stuff like that, and that's more common to happen. Chronic diarrhea is considered diarrhea that lasts longer than 2 weeks. There can be some post-infectious from lactose deficiency. There's also that, like we kind of talked about before, irritable bowel syndrome. These are basically different people, different age ranges, and kind of what you want to consider for this chronic diarrhea. So hemolithiasis. So this is a infection from a roundworm or a worm. There's also flukes, which are flatworms. So a fluke and a roundworm are different. Basically, the pathology is different. Flukes can come from like seafoods, uncooked seafoods like sushi. So that's why I won't eat sushi. I know it's sad. I know. But I won't, because the Chinese liver fluke will live in your lungs for 20 years and go undiagnosed and have babies, like 1 million babies per day. And I just can't do it. So I'm glad I shared that with you, because now I feel better. There's roundworms, which can also cause infection too. There is pinworms that you might see, or you have that history of rectal itching. The pinworm lives in the anus, and then at night it comes and feeds on the stool that's left around the anal sphincter. So that's disgusting, but that's when you itch, okay? There's an Ascaris, okay? Ascaris lumbricoides. So you ingest the eggs and the parasite lives rather in the lungs, and then they go to the intestine and lay a bunch of eggs, and then they go back to the lungs. So they could have some sort of a cough, maybe abdominal pain, and they may give you, just spoon feed you the diagnosis and say that they see fragments of worms in their stool. And so you're going to do ova and parasite analysis, most likely looking for the eggs. Pinworms. So here's the pinworm. They actually do the Scotch tape test. That is a real test. At night while your kid's sleeping, you actually go in there and put Scotch tape right over their anus and then pull it off and then take it to the lab the next day. Then they look at it under the microscope and they can see if there's pinworm on there or
You don't
not.
have to leave it on overnight, right? You can just.
No, you just kind of like touch it on there and go for it. But then you give them this albendazole or mebendazole, and that usually helps. Questions? Does do the Zoomers? Do you guys got any questions? Sorry, I've been seeing your chat, but you're answering the questions, and I'm really slow to get to them. Too many things going on. Zoomers? Nope. All right, cool. All right, guys, good luck. Let me shut this down.
Are we doing
You wanna do like a little review of your stuff
I'm not ready to do a review yet. When's your test? Monday?
Monday?
Okay, we'll do a review.